All right, so again, 152 exam to review. Here we go. We still got some. All right. Whoever just joined on your iPhone, can you change your name so that your name is on your login? This way you get credit for being here. All right. So start with active listening. Spend a lot of time talking about communication. So active listening is probably the most important part of communication, right? Especially that therapeutic communication that we are going to use. Therapeutic communication is just the interaction between nurses and our clients, focuses on both their physical as well as their emotional needs. Um, and so these interactions are you are going to require the use of effective communication strategies in order to provide support for the client. So we have a variety of those. So some of the key factors in active listening, right? The purpose of the communication, right? The health related reason for gathering data or giving information. Why are we having the interaction? um, Disciplined attention. So, right, really focusing in when you're having that conversation, right, with your client. Don't assume accuracy of information without checking it out. Right. So when you are gathering data from your client, right? Make sure that we can ensure that the information that we're receiving, whether it's going back and looking at the chart or asking family members, um, clarify what you think you understand the client is saying and ask further questions. Focus all of your senses, right, to clues the client may be communicating. And we know that sometimes this can be a little hard, right? When we're having a conversation, sometimes our minds tend to wander. But in active listening is really focusing in on what the client is saying. A common mistake in listening is to listen to the words, but not really hear the words, right? So understanding the meaning of words. So here are some different active listening behaviors that we use when we are using our active listening skill. So restating is just repeating what the patient said in a slightly different way. So I think the book uses the example that if they say that my chest hurts, I can't sleep at night, restating that back to them would be, you've been unable to sleep at night because your chest hurts, right? It's just restating it in a different way. Clarifying is asking a closed-ended question in response to a patient's statement to be sure you understood. So if the client says, my chest hurts, right? Exactly where does your chest hurt, right? Even if they want to point to where their chest hurts. Reflecting is putting into words the information you're receiving from the client at an effective communication level. Um, I'm trying to remember the example from the book. The example from the book here is tired of what is it? Sick of healthcare providers. I don't remember exactly. And not, I'm sick of healthcare providers and not getting any answers or something along those lines. And so, an effective way to, reflect that would be you're upset with the lack of answers, right, that you're getting from your healthcare providers. Paraphrasing is expressing in your own words what you think the patient means. They say that, they don't think that they're being told the truth. And so you can say you believe that you've not received all the information, about your health condition. Again, it's just like when you're writing a paper, right? And you're reading stuff in an article or a textbook, and you have to take that information and paraphrase it to put it into your paper. Minimally encouraging, those are the words, right, to encourage someone to continue. So, when you think about it, and just listening to somebody tell a story or talking about something that's happened to them, and you're like, uh-huh, right, go on, what happened next? You're just giving them those little words to encourage them to keep going. Remaining silent. So silence, I know sometimes can be very uncomfortable, but there's a lots of reasons why silence is good. It allows people to gather their thoughts. It allows them to reflect. Um, and so, avoiding filling that gap with silence, it can be helpful. Summarizing is, summer is stating the data that you have given, right? So, or you've received. So you've done your assessment, you've interviewed your client, and you have all this data, and you're going to repeat it back to them and say, this is what I've heard you say. Is this correct? And that leads into validating. And so validating then allows them an opportunity to correct any information if necessary. So, you gave them all that information back, and now they can say, yes, that's correct, or no, this part is incorrect. This is, the correct part of that. Positive communication techniques, developing trust through open honesty, integrity, and dependability. We know that those are all key when we're working with our clients, and, trying to develop that, therapeutic communication. What are I statements? What are I statements or I messages?
Want to be like, I think, like basically, I don't know. It ain't you don't make it about you, but you at least show your feelings that you care.
Okay.
That what is that what it
You
is?
accept responsibility.
Right. You're accepting the feelings rather than portraying them on somebody else.
Yeah.
Right. There you go. Perfect. Right. So, you know, um, I feel this way when you do this, right? So you're not trying to put them on the defensive, right? You're still trying to maintain that open communication, but you're taking ownership of your feelings, basically. Eye contact. Eye contact, and we look at establishing eye contact. One thing that we do have to take into consideration with establishing eye contact is those cultural barriers, correct? Not every culture is going to maintain eye contact with us, but that is that is one thing that we do want to do is at least that show them that we're there. Keeping promises. you know, if you're going to come back in 15 minutes, go back in 15 minutes. Even if, let's say, I don't know, the client wants you to just sit with them for a few minutes, and, you tell them you'll be back in 15 minutes. Even in 15 minutes, if you don't have time to sit with them right then and there, go back in that 15 minutes and just say, hey, Mrs. Jones, I know I said I'd be back in 15 minutes. However, I really have something else I really need to do right now. I'll come back again. At least let them know that you didn't forget about them. That's probably one of the biggest things. Expressing empathy. Um, Empathy is the ability to understand and appreciate what someone is feeling without expressing that feeling itself, right? So being very careful. We want to express empathy with our clients. We don't want to be sympathetic with our clients, right? Because we don't want them to feel sorry. Nobody wants us to feel sorry for them, but they do want us to understand what they're going through. Using your open communication, clarifying information, being aware of body language. Body language is super important. Even your facial expressions when you're talking, making sure that you're nonverbal and your verbal communication are both match. Negative communication or blocks to communication, those generalized answers, everybody feels this way, that kind of thing. False reassurances, right? Everything's going to be okay. We don't know that everything is going to be okay, right? So we really want to avoid those. Um, Conflicting messages is another one, right? Really want to avoid conflicting messages. Probing, probing is, pushing for more information than what you really need. And so that can, really invade somebody's privacy. We don't want to judge whether it's their behavior, um, or their healthcare beliefs or their healthcare practices. If they smoke too much, if they drink too much, we don't want to judge them. We are still going to provide them with, care. We're not supporting their behavior, right? We're just providing that therapeutic relationship. Belittling is mimicking or making fun of the client in some way. It could even downplay the importance of symptoms that they're experiencing. We don't want to give advice. So that is a negative communication style. It's easy for us sometimes, right, to want to be able to give them advice, tell them what to do, that kind of thing. However, severely beneficial. And if you've not had the experience as nurses or future nurses, I'm sure, I don't know if anybody's ever, oh, you're in nursing school, let me ask you this. um, the best thing to do is to just direct them to a healthcare provider if that's what they need to do. You got to respect their autonomy for, making decisions that fit their needs, not ours, and avoid the simple answers. Clients need to be given as much information about their care, about procedures and other types of treatments. So making sure that they are getting as much information as possible. And then we have our S-bar. So S-bar, I'm sure everybody's heard of this before. S-bar is situation, background, assessment, and recommendation. Oops. So how to use it for a provider call. All right. So if I'm calling the physician about a client, all right, and hi, this is Jennifer. I'm calling from, this unit. I'm calling about Mrs. Jones in room one, and this is what's going on. The background information is going to be things like their admitting diagnosis, their date of admission, their current status, so their vital signs, allergies, IV fluids, code status, that information. Could be, I was going to say something else. I said allergies. Um, and then your assessment is what you think is going on with the patient. Um, and then based on the, signs and symptoms, could it potentially be life-threatening? And then your recommendation, is the goals of care. What do you need from the healthcare provider? So do they need a medication? Do they need another provider to come, different provider to come see them? Do they need to be transferred to a higher level of care? Okay, so again, situation, that's the reason for your call, your name, your unit, the patient name, and what's going on. The background is the admission, diagnosis, the date of the date of admission, the current status. Assessment is what you think is going on. And then your recommendation is the goal of the care. What do you think needs to be done? It's a little bit different when we're doing a change of shift report. All right. Um, with a change of shift, obviously you're not going to say, hi, my name is Jennifer, right? The background information, the situation would be your admission date, the patient's admission date, the chief complaint, and the diagnosis. Okay, plain and simple. And then the background information here would be their history, their allergies, their code status, their labs, um, location of their IV lines, their diet, how they move around, Pain management, response to interventions, if they're on isolation, things like that are pertinent to that patient. Assessment would be the relevant information. So your vital signs, uh, your pain assessment, your diagnostic studies and results, any preventative measures, like if they're a fall risk, their medications, and if they need any other, therapeutic or preventative measures like turning and repositioning, that kind of thing. And then your recommendations are the patient's goals of care, what needs to be done during the next shift, what are the education and discharge needs, any procedures that may need to be done as well. So make sure understand the difference between talking to the provider and doing a change of shift report. Conflict resolution. So when we talk about conflict resolution, what is conflict resolution?
When you have an issue with either a patient, well, with a coworker, with anyone, is finding some way to meet halfway and try to find a solution for each party involved where you can meet together as one, I guess.
Right. Yep.
Yeah.
Right. Kind of just figure out what's going on, basically, right? Um, so the conflict resolution steps. All right. So for one, we have to accept conflict as a natural part of life, right? Not everybody's going to get along. Different views, different needs, different beliefs are usually involved, right? It's something that is going to happen. Um, the next one would be to temper your own attitude and behaviors. So be aware of your initial reaction. Take a deep breath, right? If somebody comes at you and they're upset, they're yelling, right? Sometimes our reaction could be to yell back. So we want to be very careful, right? That with that. Sometimes you have to just take a step back, take a deep breath before you respond. Take time to think critically before reacting. All right. So, think through the situation before you react. Treat conflict as an opportunity to voice your own opinion and listen to the other side of the story, right? Again, not everybody is going to have the same opinions, different, same views, same needs. And so, you may have to just this is your time to take time to reflect, right? And listen to what's going on. Choose your approach. So a win-lose approach will only escalate the intensity of feelings involved. So the best choice for a solution depends on the situation, but we want to try to have a win-win situation, right? Where both parties have, they win. And that win-win approach usually involves those active listening skills, creative thinking, lots of compromise. Listen and learn. Conflicts are often based on assumptions and lack of information. All right. So, again, that's where it is, making sure that we're getting all the information. If you did happen to be entirely wrong, apologize, find out how to correct your mistake in the future. Um, and then don't dwell on the mistake. You make a mistake, just move on. Discover what is important, right? What's the core issue? And this could be anywhere from somebody's feelings were hurt or there is an unmet need. And so that, again, getting to the root of the problem is going to help to resolve the conflict. Respect one another. Okay. Conflict can be very emotional, and we know that. Um, so, always show respect despite anger, despite hurt feelings. Stay away from name calling, stay away from blaming. You want to use those I messages, right? So that, that helps you own your feelings. It prevents people from becoming defensive, and it also lets you own what you're saying. And then find common ground to create the highest common denominator. All right. So again, right? How can we have a win-win situation? Communication in the workplace is the DES script. So what's the DES script?
I'm not sure.
Have you guys seen that in your readings or your um no, nobody's heard of it before.
No.
So DES script is describe, express, specify, and consequences. So it can be used. It's a what's the word I'm looking for? It's a communication framework. And we can use it for something like conflict resolution, especially in healthcare and patient safety issues. It helps people to express their needs, set their boundaries, that kind of thing. So describe is objectively outlining the behavior, or the situation without judgment. Okay, kind of like what we were just talking about, right? This is where you're going to use your I messages. Express is E, or E is for express. Convey your feelings and the impact of the behavior, again, using the I statements. And then specify is clearly state the change, request, or solution you want to happen. And then the consequences or conclude, those are the positive, hopefully positive outcomes or the consequences of the change. And again, we want to look at that win-win situation, right? We want to avoid the um, the win-lose. But it is another method for conflict resolution. Chain of command. I'm sure everybody's heard of chain of command. And so the nursing chain of command, followed the chain of command, especially when we're looking at conflict resolution or any other issues within the workplace. So the chief nursing officer is usually the one at the top rate. That's, in your larger organizations. You have your director of nursing. You have your department heads, your managers, your supervisors, charge nurse, your staff nurses, or your staff RNs, your staff LPNs, and your UAPs. So follow who your direct supervisor is. If you're the charge nurse, depending on where you are, so this would be more like a hospital, right? Um, Chain of command, and maybe a long-term care chain of command, right? You may be the charge nurse that either reports, to a nurse manager or directly to your director of nursing. Behavior styles. So we talk about passive, assertive, and aggressive. What is an aggressive style?
It's like a form like a bully, like
Right.
yeah.
So aggressive could be more of a bully, right?
Mhm.
They kind of don't take others, um, what's the word I'm looking for? They don't take the others' feelings into consideration, right? When they are discussing, um, they're just, like I said, they're just more aggressive, but they don't necessarily understand that they're being aggressive with their behaviors. And I'm sure every one of us have met somebody that is aggressive, but it definitely violates the rights of other people. What is non-assertive or passive?
They don't speak up for themselves. They just kind of like take whatever comes their way, maybe.
Yeah. Yeah, they don't stick up for themselves, right? It's a fear-based behavior. It's self-defeating. They tend to look the other way, right? Avoid conflict. They take the easiest way out. Um, and that's not really good because their needs are not getting identified. Um, and then we have our assertive behavior. And assertiveness is another name for honesty, right? Um, and so assertiveness is not only what you say, but how you say it. So, standing straight, steady and tall when you are, and directly facing the people that you're talking with, maintaining eye contact, speaking in a clear tone, right? We have the right to express our own thoughts and feelings, right? And so being assertive is, again, it's another way to stick up for yourself as well as for your clients. And it's different from aggressive because assertiveness doesn't insult anybody, it doesn't attack anybody. It's, just saying that I count as well. And so my thoughts, my feelings need to be heard as well.
Would that be like basically like they don't want no feedback. They don't want an opinion. It's like, would it be like this is what I said and this is what it's gonna be like that? Would it be
Your
something like that?
aggressiveness,
But yeah,
aggressive behavior, is that what
so
you're talking about?
like assertive, like and they're
No.
not being aggressive about it, but like I don't know what I want to say. Like they're not rude about it, but what they say like that this is it. Like there's no end, like there's no extra like no extra answers, like no extra opinions. Like I don't know what I want to say, but
So what, like with aggressiveness, that's where, what you're saying, what you mean, that would be you're not allowing for any kind of feedback. If you're being aggressive, you're just saying that I count, nobody else counts, and this is how I feel, and this is it. This is what I want. Assertiveness is you're getting your point across. You're using I messages, so you're taking ownership of what you are saying and how you are reacting, but it's not violating their rights. Like you're still going to listen to what your clients have to say, but you're not going to get walked on either, I guess would be an appropriate way to say that, right? I mean, this is even down to, you want to take your lunch break because you haven't had your lunch break yet. That would be an assertive, right? Or not just being able, just not, sitting back and being passive about it. Oh, I didn't get my lunch break again today, like no big deal, right? So it's a way of us sticking up for ourselves, but we're doing it in a way that we're getting our needs across and we're saying what we need to say, but we're not hurting anybody else's feelings, we're not violating anybody else's right. With the aggressiveness, that tends to definitely do that. um the IDT team, which is your interprofessional uh, healthcare team, consists of, or professionals who contribute to the care and treatment of a client, right? And so they display a mutual empathy and understanding. They work together to meet the objectives. They promote positive client outcomes and restore health. So, members of the interdisciplinary healthcare team or interprofessional healthcare team, right? We have the nurses, which is your RNs, your LPNs, your UAPs, your, care managers, your social workers, your therapists, PTOT speech, your dietitian, your physicians, your nurse practitioners, physician's assistants, a variety of different members of that team. So, what do physical therapists do?
They help you after an accident or an injury or even like stroke to get back full, range of motion, use of your limbs, or maybe walking.
Okay, so they work more on the like muscle conditioning, strengthening, that kind of thing. What do occupational therapists do?
They help with the day to day. Sometimes they even teach you how to eat again or do daily tasks in your home. I don't know if it includes speech. I'm not sure.
And speech is separate, but
Okay.
you're correct. Your OT, they work on, their ADLs, right? Your bathing, your, cooking, doing your laundry, getting dressed, right? So they focus on ADLs and things around the house, right? Exactly. Good job. Respiratory therapists, right, work on respiratory rehab, speech therapists. So speech therapists and OT can work together with eating. But OT can help provide excuse me, like adaptive equipment, adaptive spoons, forks, things like that for them to eat. Speech therapist works on speech as well as swallowing. So they kind of work together sometimes. Um, Continuity of care. So primary nursing can facilitate continuity of care, resulting in shorter hospital stays for clients, improved communication, and a more holistic focus of care. This is like we have care maps. Care maps are a combination of care plans and critical paths. To kind of show the, direction that client is going in. Case managers keep an eye on discharge and continuity of care in the community. So by planning, directing, evaluating care throughout the client's stay in acute care. So go into the hospital, you're admitted to the hospital, you'll be assigned a care manager, and that care manager is going to follow you throughout your hospital stay. They also we'll look at the things that you need once you're discharged from the hospital. And so they go, making sure that as they're being discharged, that they have the equipment that they need, that they have the follow-up appointments, and, things that they need once they are discharged from the hospital. Case managers will follow them once they are discharged. It just depends on the organization. The strength of case management method is delivering nursing services, cost-effective quality care, right, to clients with complex needs. Um, Quality service costs are, the considerations for healthcare, right? How do we provide the best quality of care, making sure that they get what they need while trying to limit the costs to them? So delivery, give me one second, I gotta turn my light on. So delivery of nursing care in acute care settings. We have the total patient care, which is the one nurse plans care, plans and delivers care. So think of your ICU. ICUs, they may not have UAPs, so that nurse is going to be responsible for all of the care for that client. So, turning and repositioning, feeding, bathing, providing, medications, all the care. Functional nursing is according to task. Um, and then your team nursing assignments are according to capability. So you'll have an RN, LPN, maybe a UAP, and the assignments are according to what their needs. So the RN, has their responsibilities. The LPNs may do like the medications and the treatments. And of course, the UAP is going to provide that patient care. Primary nursing is 24-hour accountability. Um, and then your case or care management, they use those clinical pathways to provide for care coordination. Client-centered, relationship-centered care. Um, so client-centered relations, can't even say it. Client-centered, relationship-centered care philosophy is providing care that is respectful of and responsive to individual client preferences, needs, values, and ensuring the client values guide all clinical decisions, right? So this is where we take everything into consideration, right? Their personal values, their spiritual, their cultural, when we try to incorporate all of those preferences into their healthcare, they are the ones that are going to just, to guide all the clinical decisions. Um, it also includes giving them the information that they need in order to make that informed decision about the care that they are wanting or that they need. Your NCSBN clinical judgment model. So this is when you look at your with the NCSBN and the I'm trying to break this down the best way. Um, when you look at your NCLEX, how they build the NCLEX, and what are they looking at when they're asking the questions. When on your NCLEX, they're using the clinical judgment module. So have you guys, let's put it this way, have you guys done, some of you might not have, never mind. So recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. When you guys are working through those assignments that you're doing in why is my brain just like shutting down? The assignments that you do in your sure path, that is the word I'm looking for. Okay, so it's using the nursing process and that clinical judgment model. So assessment is recognizing cues. Your analysis is you're analyzing and prioritizing hypothesis. Planning is generating solutions, taking action is implementation, and evaluating outcomes is your evaluation, right? So again, do your assessment, you take all that information during your assessment, right? You're analyzing it and identifying what the needs of the clients are, and you're putting them in order of importance, right? What are the most important needs for my client? Your planning is, developing those short-term and long-term goals. What are the needs of my client? And then your implementation is how you are going to assist your client in meeting those goals. And then you always go back and evaluate. Did the client meet the goals? They didn't meet their goals, and we go back, right? And we look at the process again, and, analyze it, plan, and look at different interventions. So developing clinical judgment, recognizing patterns. So think about, when you're working with clients, nurses spend a lot of time with our clients, and we look at recognizing patterns. The more you work with your client, the more that you are going to see, what's the word I'm looking for? The subtle changes in your clients, right? Their vital signs, you'll be able, you'll know what their vital signs should look like. You should, be able to recognize patterns. You'll be able to recognize subtle changes in your clients, right? Applying your concepts. So as you're analyzing that data, you're going to look at, things that, um, using your nursing judgment and what right? And looking at those patterns and how you are going to address any changes. Um, and what's reflective practice? Has anybody heard of reflective practice before?
I haven't.
So, you ever have a situation, whether it's been in school or even in your personal lives at another job, where you've had a situation rise and you sit back and you replay it in your mind to try to see what you could have done better, what could have been right. It's like that hindsight is 2020, right? So reflective practice allows you, it's just to look it, you can even use like reflective journaling, even in school, like with certain situations, right? You can look back on a situation, look at what, what happened, what was done, and then reflect back and say, okay, how could we do this better? Right? How could it have been a better situation? How could we, you know, even if it's an interaction with a client that or another nurse that didn't go very well, right? It's just looking back and saying, what could we have done better? Then we have the quality and safety education for nurses, which is your QSIN initiatives. And so they anticipate that collaboration has a major effect on positive patient outcomes and improved quality of care, right? So or collaboration, especially among the healthcare team, is essential for providing positive patient outcomes, right? So when we talked about members of the IDT team or the interprofessional care team, right? Everybody working together in trying to provide the best for your clients. Um, all right, and that brings us to leadership and management. So the difference between management and oh my gosh. For management. So managers, they coordinate people, time, supplies, right, to achieve their desired outcomes. They have an appointed management position. They have a formal line of authority as well as um, accountability, whereas leadership, a little bit different. They have the ability to empower and influence people, the beliefs, opinions, behaviors, either of a person individually or a group of people, by guiding, motivating, and inspiring them to accomplish common goals and recognize their success. They may or may not have formal authority, but are still able to influence others. And these are the informal leaders, right? So when we look at informal leaders, you have a group of, let's say, group of CNAs or even a group of nurses, right? They're all equal. They all have, the same title, but there may be one of those CNAs or one of those nurses, right, that's been around for a long time. They know everything there is to know, and there's somebody that, people always go to, to help them with things, to help them find things, even for advice about situations, right? So those informal leaders are often part of our teams as well. So leadership styles and theory. So there's a lot of different leadership styles out there. So these are some. So transactional leaders, oh my gosh, the transactional leader, they focus on daily operations. Okay. So the transactional leader, they focus on supervision, organization, and performance, but clear goals, but they focus on daily operations. Your transformational leaders, these are leaders that inspire and motivate people to achieve more. They focus on that shared vision. So, again, transactional, focus on the daily activities. Your transformational, they inspire people. Authentic leaders. How to explain an authentic leader? An authentic leader is very transparent, is very ethical, right? They're gonna, there's no hidden agenda with them. Shared leaders, they empower the employees. And so with shared leaders, it's really empowering the employees to share or to have a input in what is going on. Your trying to think of what else. Then we have our laissez-faire. We have laissez-faire. Laissez-faire leaders, right? The employees make the decisions. Okay, so the leader gives the team freedom to make the decisions. And then we have autocratic leaders. Autocratic leaders, the leaders make the decisions alone, right? And so autocratic is usually good really for like crisis situations, emergencies where we need someone to take charge, right? To get everybody together. What else? And then of course our democratic and that involves the employees in that shared decision making, contingency, situational, that is just that leader adapting their leadership style based on the situation. And then we have our delegation. So um, the five rights of delegation, your right task, your right circumstance, your right person, your right direction and communication, your right supervision and leadership, right? So the task, the delegated task must conform to established guidelines. We also can't, we have to make sure that we're delegating the right task to the right person with our um, I forgot what I was going to say. Right circumstances, the delegated tasks do not require independent nursing judgment, right? So we are only going to delegate to our patients that are stable. We are just going to have them gather information, right? They don't need to analyze any information, just bring it back to us. The right person needs to be qualified and competent, the right directions and communication. So clear explanation about the task and the outcomes, when they should report back to the nurse. So clarify timeline expectations. So for example, let's say, um, I don't know. Mrs. Jones in room 10 has an appointment at 11. She needs to be up, dressed, and ready to go by
¿Tú
10:30.
tienes la llave?
So
La
you
llave.
want to make sure that
Ok.
you are very clear in what is to be happening. Katiana, can you mute, please? And then the right supervision. The right supervision and evaluation. So, it was done correctly. You want to make sure that you go back and you check to make sure it was done correctly, that you provide any feedback about what could have been done better, or if they did it great, that's awesome. And then evaluate the client. Oh, I did not have the chat up. I apologize. Oh, okay. So delegation. So before you delegate, the client must be assessed, right? So you can only delegate to stable clients. CNAs, UAPs cannot delegate. Okay, so they can't delegate. Delegation cannot be transferred. So if you tell your CNA or you ask your CNA to go get vital signs, they can't in turn ask another CNA to get those vital signs, right? They have to do it, perform the task themselves. They can refuse delegation. So if you ask ask a UAP to perform a task and they say no, you can ask them for a reason. All right. So for proper delegation, the function has to be voluntarily accepted. Again, use the nursing process when you're assigning or delegating tasks. Um, but always ask why. If they tell you they don't want to do something, ask them why, right? Because there's a variety of reasons why they can say no. It could be maybe they are uncomfortable or they don't know the process, right? Then we can provide them some additional training. Or if they say no just because they don't want to, right? Then that's a totally different situation. It's generally a little bit of a personnel issue that we may need to address. So. All right. So for you guys, any questions for me? Is there anything that I can clarify, help with?
No, I really appreciate your time today, this
Oh,
evening.
absolutely, Giselle. Anybody else have any questions?
I do.
Yes.
I want
Uh,
to know. I'm sorry, Miss Tasha. I
Go
want
ahead.
to know. I know you probably ain't never seen the test. I don't know if you've seen the test or not, but I had just looked. got onto the different theories of leadership, are we going to have to know specifically which each theory mean for the
That's what
exam?
I went through that for you.
Yeah, I know, but that's what I'm asking. Because are we going to have to remember all of that? That's what I was saying. Because
If I said it, I said it.
you
So I
said
would
what?
review it. I would
Mm,
review it, yes.
okay. All right, that's it.
So everything that you went over, that's going to be on exam.
I mean, yeah, there might be more on there, but yes.
Okay.